Okay, welcome to the third and final part of our respiratory system lesson. We left off last time with asthma. We're going to pick up with emphysema. Emphysema is the permanent abnormal enlargement of the distal airway spaces and destruction of the alveolar walls. It is a non-reversible lung condition, meaning once you have emphysema, you can't get rid of it. The alveolar air sacs are destroyed and the lung itself becomes floppy. It becomes more difficult for gases to diffuse between lungs and blood, and the lung tissue becomes fragile. It ruptures very easily. About 2 million people in the United States suffer from emphysema. The vast majority of those cases are a result of smoking. 60,000 to 100,000 have a genetic deficiency of alpha-1 antitrypsin. Chronic bronchitis is a productive cough. It's the enlargement of the mucus glands, hypertrophy of the airway, and smooth muscle. So hypertrophy is excessive growth. Acute bronchitis is temporary common lung condition. It can affect people of any age. It's different from chronic bronchitis because it's reversible and has no permanent structural damage. So it's acute, it's a specific incidence of having bronchitis. If you have chronic bronchitis, it's something that you deal with chronically, frequently, all the time. 9 million people in the United States have chronic bronchitis. Cigarette smoke is, again, a major causative factor. It is an increase in the size and number of mucus secreting glands. So what you often hear called smoker's cough, the fact that a lot of smokers cough a lot. One of the reasons for that is that increase in these secreting glands. There's a narrowing and inflammation of the small airways. Obstruction of airways caused by narrowing and mucus hypersecretion and bacterial colonization of the airways. Acute episodes are brought on by respiratory tract infections. So if you get an infection anywhere in your respiratory tract and you have this underlying condition of chronic bronchitis, this is what aggravates it and sets off an acute episode. You may undergo repeated episodes of respiratory failure. People who have this frequently develop right-sided heart failure. Smoking is a major preventable cause of many respiratory diseases. It is the primary etiology of COPD, that's chronic obstructive pulmonary disease. Smokers have more lung function abnormalities than anybody else. Smokers show more respiratory symptoms and experience all forms of COPD at much higher rates than non-smokers. The age of starting, the total number of pack years smoked, the puff volume, and meaning how deeply you inhale, and the current smoking status are predictive of COPD mortality. Passive smoking also seems to increase risk. So the children of parents who smoke have a higher prevalence of respiratory symptoms and ear infections than the children of non-smokers. Air pollution, occupational exposures, such as firefighters or people that work in certain chemical or oil and gas industries, lots of other fields, asthma and non-specific airway hyperresponsiveness play a role in the development of COPD as well. Okay, we are officially at the lungs on the anatomy side of this lesson. The lungs reside in the thoracic cavity. That's where your rib cage and spine are separated by a region called the mediastinum, which contains the esophagus, the heart, the great vessels, and the trachea. Those great vessels are the largest blood vessels in your body. Breathing in and out causes the lungs to move within the thoracic cavity. To prevent irritation of the lungs moving against the thorax, each lung is wrapped in a sac or a serous membrane called the visceral pleura. We talked about this before. You have these serous membranes around your heart and lungs because they're always moving. And if they didn't have this protective feature, they would be creating friction and heat and rubbing against things all the time and wearing themselves out. So they have this double layered sac that has a lubricating fluid in between the layers to reduce friction. Here we see all of the different structures in the lower respiratory system in the thoracic cavity. The thoracic cavity and the upper side of the diaphragm are lined with a continuation of the membrane called the parietal pleura. Between these two pleural layers is pleural space called intrapleural space, which means between the pleura, which contains slippery liquid called pleural fluid that reduces friction as the individual breathes. Pneumothorax is a condition where you get air inside the thoracic cavity but outside the lungs. Air can enter the thoracic cavity from two directions. Stab wounds, gunshot wounds, any kind of penetrating wound to the chest can allow air to rush into the thoracic cavity from outside. So when you would normally be, say, exhaling, releasing the pressure from inside your lungs, some air can get sucked in through a wound that pierces into your thoracic cavity. And now you have air in your thoracic cavity that is not inside of your lungs, so it can actually push the lung shut between the thoracic cage and the lung. The lung might develop a leak as the result of a structural deformity or disease process. That's the other way this can happen. So you either get this pneumothorax, which again, pneumo means air. So this is air in your chest is what that means. You either get it from some kind of penetrating wound that lets air in from the outside, or a hole in your lung on the inside that's letting it out of the lung and into that space. If the air can't escape, it fills the space meant for lungs and prevents the lung expansion required for breathing. This can be a life-threatening situation. Pleural effusion is the buildup of fluid in the pleural space between the parietal and visceral pleura. The fluid could be pus, it could be serum from the blood, or it could be blood. And there's different terms for that depending on which fluid is filling the space, but they're all different types of pleural effusion. The fluids affected by gravity, pleural effusions tend to move to the lowest point in the pleural space. So if you're standing or sitting up, it would go towards the bottom of the lung. If you're laying on your back or stomach, it would go whichever way was downward. If the effusion is large enough, it can have the same effect as a large pneumothorax restricting lung expansion. So just like having air pushing your lung shut, now you've got fluid that if it gets between your lung and your thorax, it can put pressure on the lung and push it shut, keep it from expanding. Pleural effusions can be treated by inserting a chest tube inserted into the pleural space to allow drainage of fluid. You do something similar with pneumothorax where you allow drainage to let things out. So with a pneumothorax, if it's from an exterior penetration, generally you'll put a chest seal on there that's like a vent so air can go out of it. It lets the air out, but then the vent closes if air tries to go in, so it only lets air out one way. Pneumothorax is often referred to as a sucking chest wound because you can hear a sucking sound as air is being pulled in. So this animation or this illustration here shows you how air enters the thoracic space. And at the bottom there, they're using a needle to withdraw fluid. The lungs are conical shaped with rounded peaks. The peaks are called the apex. They extend 1 to 2 inches above your clavicle, collarbone. The base of the lungs rest on the right and left hemidiaphragm, with the right lung base a bit higher to accommodate the liver. The medial surface of the lung has a deep concave cavity that holds the heart. So the medial surface is the surface closest to the center line of your body, and it kind of dents in on both lungs where the heart is, making space there. That's called the cardiac impression. It's deeper on the left side because more of your heart is on the left side. The hilum is the area where the root of each lung is attached, containing the main stem bronchus, the pulmonary artery and vein, the nerve tracts, and the lymph vessels. The right lung has 3 lobes, upper, middle, and lower lobes, divided by horizontal and oblique fissures. The left lung has 1 fissure, the oblique fissure, and therefore has only 2 lobes, an upper and lower. The lingula is an area of the left lung that corresponds with the right middle lobe. The left lung has only 2 lobes because the largest part of the heart is located on the left lung area. The right lung is larger, with 60% of gas exchange occurring there. Your bony thorax, again, your rib cage, your spine, bony and cartilaginous frame, providing freedom of movement, protects the organs of our chest. Includes the rib cage, the sternum, the thoracic vertebra. The sternum or breastbone is centrally located, comprised of the manubrium, the body, and the xiphoid process. So the manubrium is that top little notched part that you feel if you were to put your finger on your sternum between where your clavicles come and meet the sternum. That's where your manubrium is. Then you move down to the main part, moving inferiorly. That's the body of the sternum. And then that very little tip down at the bottom that's got a little bit of give to it is the xiphoid process. We have 12 pairs of ribs in our thoracic cage. Pairs 1 through 7 are called true ribs. They are vertebral sternal, meaning they connect to both the sternum and the vertebra. So they connect on both sides, front and back. They're true ribs. They're fully connected on both sides. Pairs 8 through 10 are called false ribs. because they connect to the costal cartilage. So if you look at an image of the ribs, we talked about this in the skeletal system, they actually attach to cartilage, which then attaches to the sternum. So they don't directly attach to the sternum. And then pairs 11 and 12 are floating ribs. They have no attachment in the front. So they attach to the vertebra in our vertebral column, but they don't come quite all the way around and they don't attach to anything. And there you see down there at the bottom, those floating ribs aren't attached to anything. Then you see moving up, moving superiorly, they're attached to cartilage that then joins with the sternum, and the top ribs are all the true ribs. Respiratory control center of the brain is in the medulla oblongata. Inspiration is an active process in which the diaphragm is sent the signal via phrenic nerve, causing it to contract and flatten downward, which increases the thoracic cavity space. So when you breathe, your diaphragm, which remember kind of divides your chest from your abdomen, when it contracts, it moves downward, which makes the space inside of your thoracic cavity bigger. That increase in the thoracic cavity volume decreases pressure, which creates lower pressure in the lungs than outside, which allows air to rush into your lungs. The ease of ventilation is called compliance. High compliance means that you have little effort required to expand the lungs. This is a normal healthy condition, is that you're in high compliance. If a patient is in low compliance, it means they have more difficulty expanding their lungs. Emphysema is one of those conditions that can affect lung compliance. The bronchioles are damaged and they're wider, which allows air into the lungs, increasing compliance, but making it much more difficult to breathe out. Exhalation is a passive act. Diaphragm relaxes, which can decrease the amount of space in the thoracic cavity. Pressure in the lungs becomes greater than atmospheric pressure, and air is pushed out of the lungs. So that's why, part of relaxing, if you're consciously trying to relax yourself, is that passive exhalation, that's just relaxing your diaphragm, letting the air leave your body. While we can consciously influence our breathing rate is normally controlled by the level of carbon dioxide in the blood. So our breath rate is generally considered to be involuntary, even though you can consciously take control of your breath. So you guys know from when we did this in class where you took each other's breath rates, we tend to control our breathing a little bit when we know someone's counting our breaths because we can control it. But the natural rate at which we breathe is determined by how much carbon dioxide is building up. So it's not actually determined by our oxygen levels being low. It's determined by a buildup of carbon dioxide. So if carbon dioxide levels rise, it means there's not enough CO2 being ventilated. When this occurs, chemoreceptors in the medulla oblongata, so they look at the blood and they sense too much carbon dioxide in the blood as it passes through the medulla oblongata. So they send signals to the respiratory muscles to increase the rate and depth of breathing. So that's one of the things that happens, for example, if you start exercising or doing a more strenuous activity. The carbon dioxide levels in your blood rise because the more activity you do, the more cellular respiration your body is doing. And the main waste product of cellular respiration is CO2. So as your body works harder, you're releasing more and more CO2 from cellular respiration into your blood. Your medulla oblongata has chemoreceptors that see that CO2 in the blood and send a signal to your lungs to work harder and faster. Other factors can change your breathing rate. It changes as we grow and mature. When we sleep, our breathing rate slows down. The rate increases with exercise or strong emotions. Yawning also affects our breathing rate. Accessory muscles include the scalene muscles in the neck, the sternocleidomastoid, the pectoralis major and minor. So these are the muscles. The diaphragm, again, is the main muscle involved in breathing, but muscles in your neck, your chest, your sides, your back can all be involved as well. While exhalation is usually passive, there are times when exhalation may need to be assisted, such as during certain diseases. Accessory muscles of exhalation assist in more forceful and active exhalation by increasing abdominal pressure. The main accessory muscles of exhalation are the abdominal muscles. They push up the diaphragm or the back muscles that pull down and compress the thoracic cage. So if you try right now, take a really deep breath and then breathe it out as hard and fast as you can, you'll feel that you're using your abdomen and often some of your back muscles to force that air out. So here's all the accessory muscles that can be involved in exhalation. Again, if you practice that, take a deep breath, exhale it as hard and fast as you can, you'll feel a lot of these abdominal muscles contracting. Lung cancer can have lots of different causes, but it's linked very strongly with smoking and the inhalation of carcinogens. So carcinogenics are things that are known to contribute to cancers. Signs and symptoms include obstruction of airways interfering with ventilation, weight loss, weakness, cough, or change in cough. So you might already have a cough, but if it starts to change and consistently be kind of a different feeling and sounding cough, often that can be tied to the development of lung cancer. Diagnostic tests include bronchoscopy, which is sticking a camera. Remember, anytime you see scope or scopy, that has to do with using a camera. So bronchoscopy is sticking a camera down your bronchioles and down your bronchus. Imaging studies, that can include things like x-rays. Biopsy, bio, remember, means life, biology. So biopsy is taking a little piece, like an actual sample out of your lungs. Sputum is the actual stuff you cough up. You can examine that. And also the patient exam and history. So looking at and speaking to the patient. Treatments include radiation, chemotherapy, and surgery. Acute respiratory distress syndrome, or ARDS, ARDS. Some of you may have heard about this lately. There has been an association of ARDS with COVID-19, the condition caused by the coronavirus. So ARDS is a form of pulmonary edema. So remember, edema means that there's a retention of fluids. Pulmonary means in the lungs. Has a very high mortality rate and very non-compliant or stiff lungs. That's why you're hearing all this talk about ventilators. Ventilators force your lungs to work effectively. They mechanically breathe for you. So in ARDS, the lungs are too stiff to effectively breathe on their own. There are many different causes. They're often caused by shock, sepsis, and trauma. So there's been some debate right now with COVID-19 over whether this is true ARDS or something that looks like it. So we're going to go ahead and watch a current video from the New York Times that talks a little bit about some of the stuff that's going on with COVID-19 and touches on ARDS.
You're looking at a virtual reality image of a coronavirus patient at George Washington Hospital in Washington, D.C. The patient is a generally healthy 59-year-old man with high blood pressure. Just days before this image was created, he was asymptomatic. But now, those green areas show where the infection has damaged tissue in the lungs. For many, COVID-19 will be mild, but for others, it's deadly. This video is about the latter path, how the virus kills. We'll start in China. 191 confirmed COVID-19 patients were in a hospital in Wuhan. 54 died. Of those 54, 50 had a condition known as ARDS. Acute respiratory distress syndrome is a condition that stops oxygen from reaching the organs.
You have air hunger. It means that they can't breathe.
There's a very strong correlation between the people who develop ARDS and the people who die.
ARDS is not unique to COVID-19.
Such a long list of causes. Infection. People with HIV/AIDS, if you get into a big motor vehicle accident and sustain multiple injuries to multiple organs, that causes ARDS. SARS and MERS. Now, things that you inhale and that can be toxic can cause ARDS. Household bleach, war gases, mustard gas and phosgene. So the people who vaped THC that was contaminated with vitamin E acetate, and those patients were also developing ARDS.
Here's what's actually happening when you get ARDS. When we breathe in air, oxygen goes down our windpipe and fills the lungs. Specifically, the small air sacs at the end of the lungs are the key to air exchange in the body.
So that's why nature has created, or evolution has created this the barrier is so thin, it's just a few micrometers in size. So the oxygen has to go through just a little bit of collagen, the cell that lines the alveolus, into the red blood cell. Once it gets into the red blood cell, then the blood takes it, back into the heart and from there to the rest of the body.
And this is the key to understanding why COVID-19 is killing people.
That entire wall of the air sac gets damaged by the virus. Think of it like a thick layer of paint on the inside of the walls of a room, or a thick layer of mold on the walls on the inside of the room. That's what it looks like.
As that wall becomes thicker, oxygen can no longer pass into the bloodstream, and your organs begin to suffocate. So if you are sick, you might be asking yourself, am I in the mild path or the serious path? A good indication is whether you have severe shortness of breath and for how long. Those are indications the virus has progressed lower into the lungs. One small study of hospitalized patients in China found that 0 to 2 days after development of symptoms, chest scans were coming back normal for more than half of patients. Keep in mind, these are patients that were sick enough to be in the hospital. But within 3 to 5 days after symptoms started, that flipped, and 91% of hospitalized patients had significant respiratory issues.
As you progress beyond the 7 to 10 day stage, that's when ARDS seems to be developing. And once it develops rapidly fast compared to ARDS developing from, let's say, another cause. And these patients seem to be doing much worse over a relatively faster period of time.
Many people have mild or even no symptoms with the virus, but the longer COVID-19 affects your lungs, the higher the risk of serious respiratory issues.
And the longer you're on the ventilator, the less likelihood you will come off the ventilator. That is the blunt truth of this situation.
When I saw this on our first patient, and you see the extent of the damage and how it affects both lungs and various parts of the lungs. And it's much more striking, even for somebody who's been in practice for almost 20 years.
And that's what happened to this patient.
Just about 1 week after being at our hospital, unfortunately, he passed away. Really, my goal of trying to get this out into the public is so that they understand the severity of the problem that we're seeing and why the social distancing and the flatten the curve and every other hashtag that's come up in the past couple weeks is just so important, is because this is a community-wide problem, it's a global problem, and it's going to take a community solution, right? Everybody has a role to play, and if you're not in the healthcare field right now, your role is to stay home, right? Because again, the virus doesn't move on its own. People move. People transmit the virus.
And the longer you're on the ventilator, the less likelihood you will come off.
Some of the signs and symptoms of ARDS include rapid shallow breathing with dyspnea, hypoxemia, and fluid accumulation in the lungs, and bronchi and crackles. Those are two different lung sounds. Diagnostic tests include arterial blood gases showing respiratory acidosis, it's a condition of being acidic, and severe hypoxemia, low oxygen in the blood, hypo-ox-and-emia, all put together. That's low oxygen in the blood. Bilateral infiltrates on x-rays with whiteouts in the lung fields. So bilateral means on both sides, meaning in both lungs. Treatment includes intubation and mechanical ventilation. Sedatives and diuretics, and in some cases, high doses of corticosteroids can also be given. Cystic fibrosis is a hereditary disease transmitted by a recessive gene. So in other words, you basically have to get this from both parents. Signs and symptoms include excessive thick mucus secretion, repeated infections, large salt losses, and difficult digestion. Diagnostic tests include a sweat test where they test what's coming out in your sweat, and they can also now do genetic testing. Treatments include respiratory hygiene therapy, mucus thinning agents, antibiotics, and pancreatic enzyme supplements. This image gives you kind of a summary of the different categories of classes of drugs used to treat respiratory disorders. So the expectorants, those help thin the mucus, typically makes it easier for you to cough them up or swallow them. Antitussives are cough suppressants, so products like Robitussin usually have antitussives in them to help you cough less. Mast cell stabilizers inhibit histamine release to reduce inflammation. Mucolytics loosen that mucus up. Glucocorticoids suppress inflammation. And then those beta adrenergic agonists dilate your bronchi. Okay, guys, that's it for the respiratory system. I'll see you in the review later.